Okay, class, let's start today's lecture. Today, tests of hearing, tuning fork test, pure tone audiometry, and other various tests. Let's start. Now, sound, as you know, is a mechanical wave and it needs medium to propagate. It's vibration of particles and can be depicted as the sine wave. Now, in last class, we learned about properties of sound, subjective and perceptive properties, frequency, pitch, intensity, loudness, quality, timbre, complexity or quality, and the range. Human ears range for frequencies 20 to 20,000 hertz, and human speech, generally speech is within this frequency range, 500 to 2000 hertz. Again, the loudness of sound, the intensity of the sound we can measure in sound pressure limit, which is simplified in decibels. Like the limit is around 140 jet engine takeoff, rustling of leaves, normal conversation at 60 decibel, whisper is 30 decibel, rustling of leaves is 10 decibel. Now, the types of sound, as you know, two types of sounds, simple sound, pure tones, it's called pure tones, which has single frequency, and the complex environmental sound, multiple frequency. Complex sounds can be music, which has a regular pattern, or a noise, a haphazard pattern of multiple frequency sounds. Now, this is a general picture how we hear. This is the vibration, sound waves coming, entering through the EAC, vibrating the tympanic membrane, amplified by the ossicles, and moving the inner ear fluids, moving the hair cells. Electrical pulse is generated, travels through the cochlear nerve, then through the brainstem, the central pathway, finally to the auditory cortex. This we have already learned. Now, types of hearing. There are three types of hearing. First one is conductive hearing loss, and the second one is sensorineural hearing loss, and the mixed hearing loss, where there is both conductive and sensorineural component. Now, conductive hearing loss is just a defect in the conduction of the sound. Actually happens in the outer ear and the middle ear. It's shown in this picture. In normal hearing, the sound waves come through the outer ear, gets amplified in the middle ear, it moves the inner ear fluids, activates, then the electrical impulses travel through the nerve to the brain. This happens in the normal hearing. And the bone conduction, it bypasses all this conductive mechanism, directly vibrates the inner ear cochlea, vibrates the inner ear fluid, generates the impulse. This is the bone conduction. So bone conduction, ear conduction is a test for the conductive mechanism and the sensorineural mechanism, both of these two mechanisms, but bone conduction bypasses the conductive mechanism. It only tests the sensorineural component of the hearing. Thus, see in the conductive hearing loss, so this conductive mechanism is impaired, the sensorineural mechanism is intact. In sensorineural hearing loss, the conductive mechanism is intact. There is conduction of and conduction amplification of the sound, but there is defect in the inner ear sensorineural component, and also there can be defect in the nerve or the central pathway in the brain. Now, here the bone conduction is normal in conductive hearing loss because it bypasses this middle ear function, conductive mechanism. But in sensorineural hearing loss, the bone conduction is impaired. In mixed hearing loss, both the conductive mechanism and the sensory mechanism is impaired. That's why ear conduction plus bone conduction is impaired. It's very simple. Now, how do we test for hearing? There are two kinds of tests, subjective tests and objective tests. Subjective tests are also called behavioral tests. It depends upon the subject, behavior of the subject. We completely rely on the subject. If they do not give you the proper response, true response, then you can't do anything. So subjective test and objective test, it does not depend on the subject, on the patient. We objectively find out the hearing. Subjective tests are tuning fork tests, pure tone audiometry, and speech audiometry. Objective tests are impedance audiometry, also called tympanometry, and auditory brainstem response, ABR, or also called BERA, BERA, brainstem evoke response audiometry, and also the Oto-Acoustic Emission. We'll discuss this test one by one. Now, generally, this is very important in clinical setting, in outpatient setting of ENT, tuning fork test. Tuning forks of different frequencies are used, 128 hertz, 256 hertz, this and multiples of these hertz tuning forks are tested. Now, the tuning fork test, the most common tuning fork tests are Rinne's test, Weber's test, and the absolute bone conduction test. These are the most common tests we perform. Now, the Rinne's test, the first one, it tests the air conduction and the bone conduction, compares the air conduction to the bone conduction. Air conduction, you just, as you learned, it tests the conductive mechanism, and the bone conduction tests the sensorineural mechanism of hearing. Rinne's test, what you do is you just strike the upper 1/3 of this tuning fork on a rubber hammer or on your elbow, and it vibrates. Then you keep 4 centimeters away from the ear, the ear that is being tested, and you ask the patient until he or she stops hearing that sound from the tuning fork. And when she or he says that the sound has stopped, you suddenly keep the tuning fork over the mastoid bone, and then again ask the patient if she still can hear the sound. And we have the interpretation for the Rinne's test. After the patient stops hearing, then we keep the tuning fork over the mastoid tip. This is for the air conduction. Now the patient has stopped listening to the air conduction, then we test for the bone conduction, keeping the tuning fork over the mastoid tip. Now the principle of tuning fork test is that normally air conduction is more than the bone conduction, because the air conduction, the transformer or amplifying the function of the middle ear, the sound gets amplified. So obviously air conduction is more than the bone conduction in normal ear. This is the principle. So PLE. Okay. Now the outcome of Rinne's test is either Rinne's positive or it is Rinne's negative. Rinne's positive, when we call Rinne's positive when there is air conduction is more than bone conduction. That means when we keep the patient's tuning fork away from the patient's ear and the patient stops hearing the sound, and when we keep over the mastoid, the patient should not hear the sound further. This means the air conduction is better than the bone conduction. This is interpreted as Rinne's positive. This happens in normal hearing and also happens in the sensorineural hearing loss, because the conducting mechanism is intact, the sensorineural mechanism is impaired. That's why even if we keep the tuning fork over the bone, there is the hearing is impaired, still impaired. Now Rinne's negative is very important. It happens when air conduction is less than the bone conduction. That means the patient, even after stopping hearing from the tuning fork kept away from the ear, when we keep the tuning fork over the mastoid, the patient is able to hear the sound. This is called Rinne's negative, and this happens in the conductive hearing loss. And it is very clear now, when we keep the vibrating tuning fork over the mastoid, it bypasses the conductive component of the hearing. So Rinne's negative is conductive hearing loss. Rinne's positive is normal hearing or sensorineural hearing loss. Rinne's positive is air conduction more than bone conduction. Rinne's negative is air conduction is less than bone conduction, which is abnormal. Happens in conductive hearing loss. Now there is again another interpretation. It's called false Rinne's negative. Actually, the false Rinne's negative occurs when there is profound sensorineural hearing loss of one ear. So when we keep the tuning fork over the mastoid of the tested ear, because the sound gets transmitted to the other ear through the vibration of the skull. So it seems that the test is Rinne's positive. It seems that air conduction is less than the bone conduction. This happens in severe or profound sensorineural hearing loss of one ear. That's why it's called Rinne's negative. Now another common tuning fork test is Weber's test. In Weber's test, we compare the bone conduction of the two ears. We keep the vibrating tuning fork, especially doing this tuning fork test, we use 512 hertz tuning fork, but in Weber's test we can use 256 hertz tuning fork test. If there is a question that there are different frequency tuning forks in front of you, and which one will you choose to do the tuning fork test, then the answer should always be 512 hertz tuning fork. But in Weber's test, you can better assess this test with the 256 hertz tuning fork. In Weber's test, we vibrate the tuning fork and we keep the tuning fork over the bony midline bony prominence of the head. It might be at the vertex or at the forehead or glabella, or you can keep it over the nasion, or you can keep it over the upper incisors in the midline. So we compare the bone conduction of the both ears. A principle of Weber test, it compares the bone conduction of the two ear. And in normal, and we have interpretation, the outcome of the Weber test is that whether the sound is lateralized to single ear or whether it is not lateralized, whether the patient hears the sound only in the one ear or more in the one ear, or it hears equally to the other ear or doesn't hear anything. So we have only two outcomes. It's whether it is lateralized or whether it is not lateralized. In conductive hearing loss, the sound is lateralized to the affected side. And in sensorineural hearing loss, the sound is lateralized to the opposite side, less affected side or the better ear. There is a different mechanism for the outcomes of this Weber test. The proposed theory is that because the bone vibrates and the normal sound is normal in normal ear, it escapes through the external auditory canal, escapes outside. When the this canal is blocked, or this escaping mechanism of the middle ear is blocked, there is conductive hearing loss. The perception of sound is more in that ear. That's why in conductive hearing loss, it is lateralized to the affected side. So using this Weber test and Rennie's test, we can at least distinguish the affected ear, whether it has conductive hearing loss or sensorineural hearing loss. If Rennie's negative comes to the tested ear, then it is definitely conductive hearing loss. If Rennie's test comes positive, then there might be two things: either the ear is normal or there is sensorineural hearing loss. And doing Weber test, we can find out either there is sensorineural hearing loss or the conductive hearing loss. Now another test, absolute bone conduction test, also sometimes called a Swabat's test. It compares the bone conduction of the examiner with the patient, provided that the examiner has normal hearing. The examiner will vibrate the tuning fork and keeps over the his mastoid, and when he stops hearing the sound, then he transfers it to the patient's mastoid bone. If the patient is still the other way around, the vibrating tuning fork is kept in the patient's ear mastoid, and the patient will tell the examiner when it stops, and after that the examiner keeps on his own mastoid, and if he still hears the sound, then the patient's bone conduction is less than that of the examiner. That means the patient has the sensorineural hearing loss. We are doing this bone conduction test, which bypasses the conductive mechanism of hearing. So this is to test for the sensorineural hearing loss. In normal, equal to the examiner, and in sensorineural hearing loss, it is less than the examiner. Absolute bone conduction tests are called ABC test. Now let's come to pure tone audiometry. It's called pure tone audiometry because we give the sound stimulus as the single frequency sound, which is called pure tone of different frequencies. This is behavioral auditory measure or subjective test for hearing. And we measure the pure tone threshold, the least audible sound, the least intensity that is audible to the patient. We measure that sound with that threshold between this frequency range from 125 to 8000 hertz. In this test, we test both air conduction and both bone conduction, air conduction and bone conduction. This is the air conduction, bone conduction bypasses this middle ear mechanism, conductive mechanism directly vibrates the cochlea. Now this is the pure tone audiometer. This is the electronic machine. There are provision for giving different frequency sounds ranging from 125 to 8000 hertz sound, and has different decibels from -10 decibel to the 120 decibel intensity of the sound. This is the earphone for the air conduction, and this is the bone vibrator, which is to be placed over the mastoid bone to measure the bone conduction. Now, what does Puritan audiometry tell us? Hearing by air conduction across frequency in each ear tells us if hearing is normal or not. First, we should find out that air conduction. What we hear in everyday sounds environment is all through the air conduction. There is normally we hear through the bone conduction. So we test the normal hearing through the Puritan audiometry. And if there is a problem in the conduction, there is conductive hearing loss, then we can tell the degree of the hearing loss. This thresholds we measure over different frequency will tell us the degree of hearing loss. And also, there's a difference between hearing by air conduction, hearing by the bone conduction tells the type of hearing loss. When we measure the hearing loss by air conduction and the bone conduction, the difference that will tell us, help us differentiate the type of hearing loss, whether it is conductive hearing loss or sensorineural hearing loss or mixed hearing loss. Now, air conduction versus bone conduction testing. This you must have known by now. Conductive mechanism, outer ear and the middle ear, sensorineural mechanism, inner ear and the auditory nerve, tested by bone conduction, and this overall everything is tested by the air conduction, including the conductive mechanism and the sensorineural mechanism. Conduction test, air conduction test, entire auditory system, bone conduction bypasses conductive mechanism. So it is the test for only inner ear. Now, about the impairment of the hearing, it gives the degree of hearing loss, how much it quantifies the hearing loss, and the configuration of the hearing loss. The hearing loss over different frequency, it might not be equal in different frequencies. There might be high frequency hearing loss, or the low frequency hearing loss, or mid frequency hearing loss, or overall hearing loss in every frequency. So it tells about the configuration and the type of hearing loss, conductive, sensorineural, or mixed. Now, things we should know about the audiogram, low to high frequency. The audiogram is a chart, is a graph. It has x-axis and the y-axis. In the x-axis or the abscissa, there's a frequency range from low to high, from 125 hertz to 8000 hertz. In some special audiometers and audiograms, there are high frequency. There might be 16,000 hertz also. And they are in octave and half octaves. It's in the multiples, 125, 500, 1000, 2000, 4000, or in the half octaves. This is the x-axis. And on the y-axis or the ordinate, there is the intensity of the sound. In decibel, the intensity of the test sound we give from low to high, from -10 decibel hearing level to the 120 decibel hearing level. So the graph, when we plot each 20 decibel is equal to 1 octave. There's from 125 to 500 hertz axis, the y-axis is the 20 decibel. And another thing of the audiogram, this is the legal document, very much important to quantify and legalize the hearing loss before and after the surgery, to check for the hearing improvement after the surgery. Now this is the audiogram graph. On the x-axis is the frequency in octaves. Starts from the 125, it's in octaves, 250, 500, 1000, 2000, 4000. Sometimes there is graph is plotted in semi-octaves also. There might be 3000 between the 1000 and 2000. And the y-axis is the loudness, the intensity of the sound given from -10 decibel to 0 to up to the 120 decibel. And every 20 decibel, 0 to 20 is equal to the 1 octave. Now, this is the this graph shows the normal hearing. The human ear is from -10 decibel to 25 decibel, and from 25 to 40 is mild, moderate is 41 to 55, and from 55 to 70 is moderate, from 70 to 90 is severe, and the profound, and this is the conversational area. of the human auditory field. Okay, now the symbols we use to plot the graph in pure tone audiometry. It's called the legends. You should remember this so you can decipher any audiogram. Now for air conduction with the masking, is everything on the right side is in the color red. On the left side is blue. So for air conduction, the symbols we use is very simple. You just try to remember with this the figure of the tic-tac-toe. These are for air conduction we use these symbols for the tic-tac-toe. Now on the right side, air conduction we use red and round on the right side, blue and cross on the left side. This is for air conduction, tic-tac-toe. Now for the masked air conduction, sometimes we use we mask the non-test ear so that the non-test ear, the ear which is not being tested, will not interfere in the test. So we mask the ear, the non-test ear. When it is masked, we change the symbol. For the right ear, from the circle it turns to the triangle, and from this cross it turns into this square. But left side is always blue, right side is always red. Now bone conduction on marks. If you compare with the ear, the right side, it's a shape of the ear. The smaller than sign, its color is red. This is the right side. Left side it will be like the left ear, oriented like the left ear. It's unmasked. And when bone conduction is masked, it is like a square bracket. This is the right side symbol. This on the left side, oriented like the left ear. The patient's right. Not your right, the patient's right side. Now ranges of hearing loss according to WHO, minus 10 to 25 decibel of hearing loss. It's normal. Up to the 25 decibel, it is considered normal. From 26 to 40 decibel, it's mild hearing loss. From 41 to 55, moderate. 56 to 70 decibel hearing loss is moderately severe. 71 to 90 decibel is severe, and greater than 90 decibel is profound hearing loss. Now just see, this is the audiogram graph, the hearing. The test is taken of the left ear. Everything is in blue, cross, and this greater than bracket, greater than sign is plotted against the different frequencies. Here at 125 hertz, it's 0 decibel. The patient can hear the sound of this 0 decibel. At 250 and in 500 hertz, the faintest sound he can hear is of around 10 decibel. But everything is above this 25 decibel line. So hearing is normal. The air conduction denoted by this cross is normal. The bone conduction of left ear denoted by this greater than sign is also above the normal hearing threshold. So this is the normal hearing, bone conduction and the air conduction. Now conductive hearing loss. Let's see the air conduction of the left ear at 125 degrees is 50 decibel, 250 is 50, at 3000 is 60 decibel. So air conduction is much below the level of the normal hearing threshold. But the bone conduction of the left ear, this is unmasked bone conduction, is normal. Bone conduction is normal, air conduction is impaired. Bone conduction is better than the air conduction. So this is conductive hearing loss. And the important feature, you just see the audiogram at a glance, is this gap between the bone conduction and the air conduction graphs. This is called ear-bone gap, also called AV gap. So in conductive hearing loss, there is AV gap, ear-bone gap. Now sensorineural hearing loss, as here you see in the high frequencies, it starts from 1000 to 4000 and 8000. Here in lower frequencies, the bone conduction is normal. Bone and air conduction both are normal. But in higher frequencies, air conduction and bone conduction are all hampered, all impaired. The patient can hear this 4000 hertz sound only at 60 decibel intensity. So in sensorineural hearing loss, all mechanisms, the conductive system also doesn't work because the inner ear is defective or the nerves are defective. So this is a kind of graph you can see in sensorineural hearing loss, specifically high frequency sensorineural hearing loss. Now mixed hearing loss. In mixed hearing loss, both the bone and the ear conduction are below the threshold, below the range of the normal hearing. Just see this bone conduction is more than 40 decibel and ear conduction is much worse, but there is AB gap. Still there is AB gap. That means there is both conductive component and sensorineural component. There is gap, but both, even the bone conduction is abnormal. So this is mixed hearing loss having both sensorineural and conductive components. So mixed hearing loss PTA has both AB gap and abnormal. Now specific pattern of pure tone audiogram, especially you remember this Karat's notch in otosclerosis. In otosclerosis, there's a specific sign at 2000 Hz. There is a dip, there is a notch in the bone conduction. This is the bone conduction of the left ear. This is a masked symbol. Here also, this is of right ear. Everything is in red. This is bone conduction. The dip or the notch in the 2000 Hz in bone conduction of pure tone audiometry is Karat's notch, and this is happens in otosclerosis, seen in otosclerosis. Now here, the right ear, the both ears testing, the results are given in a single audiogram. So you should not confuse. This is the unmasked ear conduction of the right ear. This is low frequency loss. And here this is the left ear conduction. Left ear is normal. Here the bone conduction of the right ear is normal, but the ear conduction of the right ear is abnormal. There is AB gap, so there is conductive hearing loss of the right ear. But the left ear depicted by blue symbols, cross, and the another sign is normal. So left ear is normal, right ear has conductive hearing loss. From the single pure tone audiogram, you can assess the both ears. Sometimes they are given in separately for right ear audiogram, left ear audiogram, or sometimes both ears are given in the single audiogram. Now another test, subjective test, is speech audiometry. Instead of pure tone, we use recorded voice of different intensity in speech audiometry. Now the first test is speech detection threshold. This is a basic test for speech. Here the recorded voice is given in different intensity, and the speech detection threshold is the intensity level at which the listener can barely detect the presence of speech. In 50% of the time, 50% of instances, the patient can detect that there is some speech going on. This is called speech detection threshold, and this is equal to the PTA average obtained at 500,000 and 2000 Hz. Actually, when we give the report of the pure tone audiogram, we calculate the average loss in decibels of the three frequencies, 500, 1000 and 2000. We do not give the frequency loss, hearing loss in decibel for every frequencies, but we calculate the average of these three frequencies when we give the PTA report. So this speech detection threshold is equivalent to the PTA average. That means it's equivalent to the PTA. It's the faintest sound which speech which the patient can hear 50% of the time the stimulus is given to him. Now another thing is speech reception threshold. The first one is speech detection threshold. This is speech reception threshold. The two syllable words, spondy, we call it spondy words, the phonetically balanced words. It has two syllables and the equal stress, just like downtown, back up, make up, this kind of two syllable words. We give as a stimulus at different intensities, and the patient should repeat the 50% of the time, the faintest, the lowest intensity speech, when the patient could repeat the words given to him, spondy words, for 50% of time is detected as the given as a speech reception threshold. It is measured in decibels, just like pure tone audiometry, and its speech detection threshold. It is usually 8 to 9 decibel more than the speech detection threshold. Now, another thing is speech audiometry, speech discriminatory score, SDS. The monosyllable words are given as a stimulus to the patient's ear, and these syllable words are given at higher intensity, 50 decibel higher than the speech reception threshold. So patient could clearly hear the sound. And we calculate the percentage of the words the patient correctly recognizes. So in the normal patient, when this speech discrimination score is more than 96 to 100%, is 96 to 100% of monosyllable words, he can correctly recognize those words given at 50 decibel higher than the speech reception threshold. In conductive hearing loss also, it is not much impaired, 90 to 100%. So, but in case of sensorineural hearing loss, it is very low. The patient can hear the sound, but patient cannot correctly recognize the sound. So in sensorineural hearing loss is low, and the retrocochlear also, it is also very low. This is because the inner ear also works as the frequency analyzer. Now, objective tests, which doesn't depend on the patient. We objectively find out the hearing assessment. The first one is impedance audiometry. It's called impedance audiometry because it measures the impedance, the resistance of the tympanic membrane. It includes tympanometry and the acoustic reflex, also called stapedial reflex. Now, tympanometry, it records the resistance of the conductive mechanism of the ear against pressure changes of the external canal. Here, what tympanometer is, we keep an airtight chamber in the external ear canal. We have the probe, and there is a mic in the probe, and there is a port for increasing the pressure. We gradually increase the pressure in external auditory canal, and we give the sound from a source, and we measure the amount of the sound reflected from the tympanic membrane as it stiffens by a mic in the probe. So there are different type of tympanogram we achieve through this test: type A, B, C, AS, AD, and type D. So in normal tympanogram, it's type A, and type B occurs in if there is an impaired resistance or impaired compliance. The resistance is also measured as the compliance. The increased resistance is decreased compliance, the mobility of the tympanic membrane or the elasticity. Otitis media with effusion, we get type B tympanogram if when there is tympanic membrane perforation, or if there is leak in the probe, or there is middle ear mass like wax, we get type B tympanogram. Type C, we get initiation tube dysfunction. Type A is in otosclerosis or tympanosclerosis. Type AD in ossicular dislocation or the atrophic TM. And in type D, scar TM or normal hypermobile tympanic membrane. Here the graph is, the x-axis is the air pressure given to the external air canal pushing the tympanic membrane. It starts from the negative pressure, minus 400 millimeter of water, and till the 400 millimeter of water. And we measure the energy flow or the compliance of the, in the arbitrary units, we use the compliance or the stiffness or the elasticity, whatever you say, of the tympanic membrane on the y-axis. In type A tympanogram, when there is negative pressure in the external ear canal, the tympanic membrane is pulled outside, so the compliance is less. But when we increase the pressure from negative to 0, this is the normal, there is no pressure in the EAC canal, then the compliance is highest. That means tympanic membranes is most elastic and vibrates most and is able to transfer the conductor sound highest at the neutral pressure. And again we increase the pressure, again the compliance and elasticity decreases. This is normal tympanogram, type A tympanogram. Now type C tympanogram, the peak occurs at around minus 200 millimeter of S2, negative pressure. When you pull out the tympanic membrane outside, then the compliance is higher, and as we go towards the neutral and the positive pressure, the compliance decreases. This happens in eustachian tube dysfunction. When eustachian tube dysfunction occurs, the middle ear does not get ventilated and the ear gets observed. There is negative pressure built up and the tympanic membrane is pulled inside. And when we apply the negative pressure from the external auditory canal, the tympanic membrane comes the neutral position at around minus 200. So compliance is highest at minus 200 millimeter of water. This is type C tympanogram occurring in eustachian tube dysfunction. Now type B tympanometry. There is no change in the compliance because there is the obstruction in the conductive mechanism. Either there is wax in the external auditory canal, whether the probe is loose and you are not being able to maintain the pressure in external auditory canal, or there is fluid inside the middle ear which decreases the compliance. So there is no increase in the compliance. It looks like a straight line or a very low slope curve. This is type B tympanometry. And type A is occurring in otosclerosis. The tympanal membrane is stiff because of the stapes fixation, or the tympanic, there is a tympanosclerosis. Tympanic membrane is not that much elastic, so there is not much increase in the compliance throughout all these different pressures. S is for otosclerosis. Now this is the type A. This is type C, highest peak, highest compliance at minus 200 millimeter water pressure. This is normal range. This is type A. This type AS. And type D occurs in ossicular discontinuity or very thin, frail tympanic membrane. At neutral, the compliance is very high, or sometimes it is infinite. D for discontinuity of the ossicles. So type AD occurs in ossicular discontinuity. Now another thing, acoustic reflex or the stapedial reflex. As you already know, this is the protective mechanism for loud sounds. Stapedial muscle contraction occurs in response to loud sounds, loud noise. Now we voluntarily give a sound, loud noise around 7. We give loud sound 70 to 100 decibel above the hearing threshold, and this test is done especially to differentiate between the cochlear or the retrocochlear lesions. This is a reflex arc where the afferent limb is formed by the cochlear or the 8th nerve, and the efferent limb is formed by the facial 7th nerve, which supplies the stapedius muscles. The protective reflex. Loud sounds comes, it is detected by the cochlea as a loud sound, travels to the cochlear nerve, then goes to the cochlear nucleus, then superior olivary nucleus, then it travels to the contralateral side also, and on the ipsilateral side also supplies the facial nerve nucleus, from there to the facial nerve, and it contracts the stapes muscle, stiffening the stapes bone, restricting its mobility. It's a protective mechanism, and we use it to differentiate between cochlear or the retrocochlear pathology. In conductive hearing loss, there is no reflex present bilaterally. When you give a loud sound in the single, the test ear, we do not observe the reflex in both ears. And this acoustic reflex is measured by the tympanometer only, because the sound is unable to reach the inner ear because of the impairment of the conductive mechanism. So absent bilaterally when tested ear has conductive hearing loss. And to elicit this level, the bone conduction must be better than the 60 decibel. Better than it should not be more than the 60 decibel. The hearing loss, the sensorineural hearing loss must not be more than 60 decibel in order to perform this acoustic reflex test. Now, if there is acoustic reflex is negative in the tested ear, but it is positive in the non-test ear, then this indicates retrocochlear lesion. The reflex arcs, the negative, when there is retrocochlear lesion, it does not passes to the reflex. The reflex is present in the contralateral ear, and if there is acoustic reflex is present in the ipsilateral ear, the test ear, but negative in the contralateral ear, then it indicates the brainstem lesion. And since facial nerve is also included in the afferent pathway of this reflex, we can also test the function of the facial nerve through this acoustic reflex test. Now, another objective test for hearing is ABR, auditory brainstem response, also called BERA, brainstem evoked response audiometry, ABR or BERA. Here we record the electrical activity of the occurring during the sound transmission when the electrical pulses generate through the generated by the cochlea. It passes through the nerve, through the brainstem to the auditory cortex. All these generated electric impulses are captured by the surface electrodes, just like the ECG. And this is very sensitive for retrocochlear lesion. This is an objective test. Here the patient cannot interfere with the result of the test. Now we have basically five waves we obtain in the ABR, just like the QRX complex, Q waves, T waves of the ECG. We have three waves: wave 1, 2, wave 3, 4, and 5. And wave 1 and 2 is generated by the electrical impulses from the cochlear nerve, eighth nerve. Wave 3 is from the cochlear nucleus complex, wave 4 from superior olivary complex, and the wave 5 generated at the lateral lemniscus. There are 5 waves. This is the electrical waves captured by the ABR machine. This is the first wave, first and second wave by the eighth nerve. There are 5 waves. Here in the retrocochlear pathology, we can see the absence of these waves, and also in sensorineural hearing loss or anything, we can see the delay in the peaks of the waves. Now, another objective test is Oto-Acoustic emissions. These outer hair cells of cochlea, they generate sounds. Spontaneously, they generate sounds. This is the normal biological activity of the outer hair cells. And these very faint sounds, low intensity sounds, is captured by the special microphone in this Oto-Acoustic OAE measuring machine. There are 2 types of Oto-Acoustic emissions: spontaneous generation, spontaneous emission, and another one is evoked Oto-Acoustic emission. We evoke this sound from the outer hair cells by giving another special frequency sounds from outside. Spontaneous OAE is present in 50 to 70% of the people, and OAE is especially used in newborn hearing screening because a newborn baby cannot do any subjective test. This objective test for hearing screening is done for newborn babies. Oto-Acoustic emission, it has just 2 results: pass or fail. If we detect the Oto-Acoustic emission, the test is pass, and if we do not detect the Oto-Acoustic emission, it is fail. And the spontaneous occurs only in 50 to 70% of the people. So if the result comes fail, we should proceed to the ABR, where ABR will detect the electrical activities and can pinpoint the lesion in the hearing mechanism, whether it is cochlear or the retrocochlear. Now this is the end of the class. Now take the questions. Why is there deep in 2000 Hz in otosclerosis, carotenoids? Especially otosclerosis involves the faulty calcification or the bone metabolism of the stapes and sometimes the cochlear bone also, the bony labyrinth which houses the cochlea. So when the bone is stiffened, there is certain unclear changes in the bone. This why the 2000 Hz dip occurs in bone conduction is still unclear, but the normal mechanism, it is due to the faulty bone metabolism and the faulty bony conduction. And in all otosclerosis, 2000 Hz is not mandatory, not necessary. Sometimes you get a different pattern called spooky bite pattern in the pure tone graph, audiogram. Cookie bite pattern is also a feature of otosclerosis. Renes test is nothing, it's very simple. It tests both air conduction and the